active drug users, excuse me. Amanda's current role is at CLARE Matrix as Director for Outreach and Education on one of the California State Response to Opioids and Stimulant Use Grants, the Hub and Spoke project, as some of you may know about, focusing on removing barriers to those accessing treatment for opioid use disorder and or stimulant use disorder, decreasing stigma, working on state policy, and ensuring equity in treatment. And then some of her really exciting recent work. Amanda is chair for the Integrated Health Committee at the Los Angeles Regional Reentry Partnership, working on health equity for those impacted by mass incarceration, as well as commissioner for Supervisor Sheila Kuehl on LA's county's Alcohol and Other Drugs Commission. Amanda, thank you so much for all that you do for us, and thank you for being here tonight to speak with us.
Thank you. The bios are so fucking embarrassing, but thank you. Thank you all for being here. It's really exciting. I told Tucker that I would try to do this in 50 minutes, but if any of you have spent more than a minute with me, it might be a project, but we will try to get through it all. I have a lot to say. I also have pretty significant ADD, so I can get a little tangential and scattered. So feel free to bring me back around if that happens. Okay, so we're going to be discussing structural violence against those that use drugs. And wait, that's my screen. That's okay. Oopsies. Got it? It's okay?
That's perfect. Thank you.
Fabulous. Thanks. All right. So there's gonna be some things I skip over. There's gonna be some things you've probably heard a gazillion times, just kind of a rough overview of harm reduction. There's gonna be a couple things that I repeat just because I think they're really important points. So I kind of always start most all of my trainings by discussing how conversations around substance use can be triggering for some folks, and that it can evoke a lot of really strong emotions. And so to kind of try to center ourselves, because most of us have personal connections to substances, and so we tend to project those viewpoints onto the conversations and to others. Additionally, most of us have been ingrained in the United States version and their narrative around substance use, where it's kind of themed by moral weakness, criminality, and interdiction. And so I just kind of always want people to pause and really think about the judgment values that we put on folks, and really to take this time, and hopefully by the end of this training, to really think about the complexities that have brought us here, which include structural racism, mass incarceration, housing and health inequity, to name a few. I believe that individuals don't deserve the brunt of kind of our collective rage, and the practice of harm reduction really has the power to help us focus our rage where it really should go, which is systematic failings that make pleasure elusive in this country and death really quite too easy. So I always encourage people to kind of take a moment also to imagine being a subject or a person that is so stigmatized that the hateful activities of shunning and punishment are somehow transmogrified into a kind of a perverse type of tough love. You really don't see it in any other spectrum of behavior. And these things lead to alienation, stigma, shaming, and ultimately death. And so with that, we really need to resist the narrative and the ideology that encrypts people who use drugs in a plaster of stigma, frozen and incapable of coming together and reaching out. So. All right, brief terminology. What are substances and why do people use them, right? So the substance being anything that produces a change in the body, brain, or both. And I think it's really important to discuss that motivations vary from person to person, and that a lot of times there are really beneficial motivations for those. But it's really important to understand some of the motivations because it's important to inform harm reduction strategies to reduce risk and then maximize benefits for those who want to continue using their substances. Also, understanding motivations help us to support effective treatment and recovery planning for those who want to potentially change their behaviors. So these are some of the reasons: feel good, be more productive, regulate behaviors, anxiety, ADHD, schizophrenia, to enhance sexual activity, food insecurity, curiosity, social isolation. So these are some of the dominant theories of addiction. I have a lot to say on this. I'll try to keep it concise. So the concept of the addicted brain kind of appeals to the intuitive idea that because recreational drugs exert their actions, for example, eliciting euphoria through specific brain structures, there must exist a discernible and meaningful brain difference between those who are afflicted with addiction and those who are not. These differences are then seen as the cause of addiction and therefore targets for treatment. And so the diseased brain perspective is appealing because it offers treatment approaches that seem straightforward. But despite the kind of solid, people's solid or views of solid scientific consensus, there's actually really virtually no data in humans indicating that addiction is a disease of the brain in the way that we understand diseases of the brain, like Huntington's or Parkinson's. And so those things, those ideas that it's rooted in this brain disease model contributes a lot of times to unrealistic, costly, and harmful drug policies. And so a lot of times policy is kind of guided on the fact that if a problem is a person's neurological state after exposure to a drug, then either the drug must be eradicated for society through law enforcement, or an individual's brain must be treated. And so that's a myopic approach, and the socioeconomic and the societal factors that contribute to drug use or chaotic drug use are considered really a footnote in the research, clinical practices, and policy. So it's really important to understand that most people that use drugs do not become addicted to drugs. It's a really small percentage that do. Okay. By the way, most of the research is really moving towards the learning disorder model. Okay, so harm reduction is an umbrella term for interventions aimed to reduce the problematic effects of behavior, and it's a broader fight to abolish harm in policy, education, and healthcare. So it's a practical set of strategies that reduce negative consequences. In relation to drug use, it incorporates a spectrum of strategies, including managed use and abstinence. People kind of forget that abstinence is actually on the spectrum within harm reduction. There's kind of this idea that abstinence is not part of it, but harm reduction is the entire spectrum. So one being safer drug use, and then the other, or the opposite end, being abstinence. But harm reduction strategies are to meet people where they're at. So I'm not going to go through this because I'm guessing most of you have had this, but I would really encourage everybody to look at the Harm Reduction Coalition's website. They have kind of quite a endless resources around harm reduction principles. Got the word eventually. So why harm reduction, right? So harm reduction really is a movement more than just options for care. It's part of a larger advocacy movement with kind of the focus really being on undoing and dismantling years of system failures, like the war on drugs. And it really is a framework for understanding structural inequalities. So harm reduction has downstream and upstream drivers. So the downstream drivers are easier to accomplish, things like handing out naloxone, ensuring access to treatment, and the upstream drivers are kind of the causes of the causes of the causes. And we primarily tend to just look at individual behaviors instead of looking at the structures and systems. And so harm reduction really aims to look at both sets. Okay, I forgot my little note here. So harm reduction kind of, actually, I'm going to go back to that later. So harm reduction in everyday settings, right? We have sunscreen, naloxone, condoms, helmets, designated drivers, needle exchange, seatbelts, nicotine gum. This is the clinical way of looking at substance use on this spectrum. Sorry, I put my notes out of order. Told you, really good at this. And then this is the harm reduction continuum's view of harm reduction, right? It's the understanding that drug use really traditionally is taught on absolutes and values. Either someone's sober or they're addicted, or they aren't, right? And the vast majority of people really who engage in drug use, as we said, don't develop a substance use disorder. We see this all the time. We see people going out for drinks, and it doesn't mean that they necessarily have alcohol use disorder. And so this spectrum I really appreciate, because it looks at the whole, the upstream drivers, but it also kind of talks about like the protective factors there that people have that promote kind of more managed use, right? And so we understand that when people are transitioning through a spectrum of drug use, the access to healthcare and services and close supportive social relationships are actually the things that move people through these transitions safely. So this is the Transtheoretical stages of change model. And if we were to overlap that with a harm reduction stages of change model, this is pretty much what it would look like. I don't know when the screen is being shared. If I move around people's faces, does that change for you all? No. Okay, good. Okay, so what harm reduction kind of looks like, right? So abstinence only says risk is binary, where harm reduction says it's on a spectrum. Abstinence only says that drivers of risk are individual. Harm reduction is looking at it, it's contextual. High risk behaviors with an abstinence model is a personal failure, where in harm reduction, and this is what I love, is an unmet need, right? What are we looking for? And then in messaging, abstinence only messaging is moralistic, where harm reduction is compassionate. And then the expectation within abstinence is 100% risk reduction, and harm reduction takes a little bit more of a pragmatic approach, understanding that we actually are never going to get drugs out of our society, ever. And that's an okay thing. So history of harm reduction, phase 1 of harm reduction is really considered the triumph of public health, but it really stressed the primacy of HIV and AIDS over addiction. Addiction wasn't incorporated or folded into the model in the United States. It was, however, a paradigm in all the harm reduction models all over the world. So phase 2 is the psychodynamic, cognitive, and humanistic addiction psychotherapy. It's science and evidence-based, and the first formal appearance is in a paper by Tatarsky in 1997. Phase 3 is known as gradualism or recovery-based harm reduction. And so it's a stage where problematic, quote unquote, drug users could engage in states where they went from active or chaotic use to safer use, to states of abstinence or moderation, right? So kind of understanding that people are going to consistently move through a spectrum throughout their life. They might not stay in one. They might go abstinence, they might go back to chaotic use, and they might kind of just constantly move. And then phase 4 is harm reduction psychotherapy. And so this understands how substance use is actually meaningful for many people. And people use substances in what we consider problematic ways for a variety of reasons, and that those reasons are really to be respected. It's not our choice to decide what is or isn't good for somebody else. Okay, so a little bit further in depth. So history of harm reduction, we tend to start in this country, as we always do, by things that were only created in this country. And guess what? Harm reduction happened a long time before. Harm reduction is first formally in the 1920s in the British system. There's the Rolleston report. In the 1960s to the 1980s, there's the Dutch model, which is the users union and the syringe exchange. Late 1980s in Liverpool in the UK is the Mersey harm reduction model, and the grassroots advocates. This is when they start kind of popping up, and they start pursuing harm reduction models. And then in the 1990s, we have Canada, HIV and AIDS, and this is when substance use kind of starts getting folded in. And then we have our two biggest heroes in harm reduction that we tend to idolize, Dave Purchase and Dan Big. So harm reduction in the United States has a pretty fascinating history, and it really takes its inspiration from multiple movements and strategies. So it takes a lot from the Black Panther Party survival programs, right? So free breakfast for children. The reason why we have free food in the LAUSD school district and the school district generally is because of the Black Panthers Party survival programs. The reason why we have federal qualified health center, Black Panthers Party survival program, right? So the 1972, the Panthers Manifesto is updated to include free healthcare for oppressed people. We also have the Young Lords, their launch of auricular acupuncture program for heroin users in the South Bronx. At this point in the 70s in the South Bronx, we have the highest consumption of heroin in the world. So this is, if you haven't heard about this, this is fucking fascinating. The Lincoln Hospital takeover, the Young Lords and the Black Panthers literally take over a hospital, right? They understand that their people are not being taken care of. And what do? They fucking take it over and they make it a center. And guess what? People have to listen. So it's the Lincoln Detox Center. There's an incredible, a very short podcast that I would really encourage people listening to. I can't remember what it's called, but I'll send it. But we have Matula Shakur and then COINTELPRO. So when the FBI and the CIA are watching the Black Panthers, Matula Shakur is still in prison, and COINTELPRO was basically a way to like break up the party. But this was kind of really the first real spotlight on addiction treatment within marginalized communities. It also takes a lot of its roots in the women's health movement, emerging from the 1970s feminist activism and the fight for reproductive health. By the way, what's interesting and fascinating for me is, this might be controversial, that our feminist movement, which promotes autonomy, does not include drug use or health in that, right? So we're talking about we are supposed to choose what we can and can't do with our body. And then we're also saying, but other people aren't allowed to choose what they put in their body, right? So there's, the feminism is a little bit broken. And so I think that's just something we got to start thinking about. So the grassroots response to the AIDS crisis in the 1980s and beyond, we have Marsha Johnson and Sylvia Rivera in the 80s. So despite a 1984 CDC recommendation that syringe access would protect Americans from HIV, since 1988, US law has prohibited the use of federal funds for these supplies. The Biden administration has allocated, though, $30 million for syringe purchasing despite the ban. Okay, so looking at framework again of harm reduction is that it falls into all these other frameworks, right? It's an anti-carceral movement. One of the biggest threats to public health is policing. It's anti-capitalist. Our bodies belong to us. No one owns us or our healthcare. Harm reduction work has historically been illegal, and it's always really been pushed back on by the medical industrial complex. It's anti-racist and colonialist, right? Because it's working towards a collective liberation. It's pro-indigenous and no borders, healing justice, bodily autonomy. It takes tons of root in the self-determination empowerment theory. It takes a lot of root from disability justice, right? So the understanding of self-determination and how that plays out in people's lives. Reproductive justice, trans justice, trauma-informed, and then abolition. So really understanding how the war on drugs actually has its hands in every system. In drug courts, in social work, in DPSS, right? Like absolutely everything becomes an extension of the carceral state through the war on drugs. Think about like all the mandated reporters in everything, right? So there's that. Okay. So as harm reduction is based on acknowledging the dignity and humanity of people, and it really brings them into the community care. So some of the modalities within harm reduction are syringe exchanges, right? And syringe exchanges are incredible warehouses of information. A lot of people think, oh, somebody goes there just to get new supplies. No, they don't. They go there to get support, community, connection, every kind of resource under the sun, food, right? It's like, it really is a place where people, at least my work with syringe exchanges has always been that it's the place where people are seen as human beings and given dignity for the first time in a very long time. And it's a place where we can start to rebuild relationships. It also provides safe use education. So even when we go back to the idea of bodily autonomy, we're giving people this information and they can choose what they do with it. So we can provide them, you know, at syringe exchanges, again, people kind of forget, you can go to a syringe exchange and someone can teach you how to inject safely, right? It's not just the supplies, it's also giving you all of the education around it. First person language fits in the harm reduction interventions, pharmacological interventions, so some of the medications, naloxone and overdose prevention, Good Samaritan laws, prescription grade heroin, don't know if we're ever gonna see that here, overdose prevention sites, drug checking, contingency management, motivational interviewing or decisional balancing, acupuncture and herbal treatment, peer support, and policy reform. So acupuncture, again, I know I just kind of briefly went over it, but it goes back to Matula Shakur and the Young Lords. The reason why, it's just a fascinating story. Basically, they decided it was another intervention in modality. They learned how to do auricular acupuncture, and they started setting up their own clinics. They still do it in the South Bronx, and they do it on the East Coast. I don't see it very often here. But when I worked in a syringe exchange in England, they taught all of us how to do it. And it was a program that the participants really, really loved. Okay. So understanding within some of the harm reduction practices that healing is not linear. Relationship is absolutely everything. So the relationship of the person to that substance, the relationship of the person to their community, and then the relationship of that person to their provider. Practices within harm reduction should be non-condemning. They should be creative. We should always remember that the person or the participant that's showing up is the expert. The person in that culture has their answers. Now I don't remember where my note went for that, but we forget that for most Indigenous communities, they have been keeping their communities safe and reducing those harms before harm reduction ever came to be in the English language. And it really, in those capacities, is not just limited to substance use. It's listen, you know, colonialism, racism, etc. It's based in reality. There's no predetermined outcome, and then there's peer-to-peer within harm reduction practices. Okay, so levels of harm reduction. So what I love about harm reduction is the understanding and looking at the systems, again, so the structures, understanding that there's individual, there's community, and there's institutional. That behaviors, you know, we tend to kind of always just look at people's individual behaviors instead of understanding the whole person and then the whole system and the world that they operate in. Hold on, I just need to see what slide I'm on. Okay. I did, if any of you know me in real life, this is not surprising. I somehow printed out two bizarre different sets of notes. So I'm like trying to realize which ones are the correct ones. Okay, anyway, here we go. So individual and community level, right? So it's really important to think about why people who use drugs might not want to engage in treatment services. One, traditional drug treatment is just not an option for many people. So the same argument that we hear all the time about why are homeless people homeless? There are shelters, there are beds, they're turning them down. There's this pervasive myth that there is an abundance of resources. There is not an abundance of resources. I don't know if anybody here has tried to get somebody into a residential treatment program. I work for a residential treatment provider. It is a shit show. It is virtually impossible to get people into treatment, right? We create endless barriers. If you call, like let's for example, you call LA County SAPC SASH line, right? You call them and you have an operator. And this is somebody you've never spoken to ever in your life. And suddenly you are supposed to disclose your entire history so they can score you and decide what level of care you need. Then they're going to refer you to a treatment provider. They usually don't have actually accurate or updated information. They don't even know that that person has a bed. They send you the treatment provider. Then you have to go through that whole series of an ASAM essentially again. Then when you, let's say you get in, you have to go through an ASAM again, right? There's just like these constant barriers to get into treatment. And so I say that just to say, like, when you hear people say things like people aren't doing it, there's plenty of treatment, there's a lot of resources, there really isn't. There is not a plethora of resources. But also we need to understand that a lot of people might never want to quit, and that's okay too. Treatment services really lack cultural and linguistic competency. So that's a barrier for many people. For folks that are from marginalized groups, especially multiple marginalized identities, so let's say Latinx and LGBTQIA+, right? Like to get your needs met in these services are incredibly complex. Faith-based or non-faith-based. A lot of folks, we criminalize poverty here all the time. And so a lot of folks maybe might not start treatment services because they're very aware that once they get arrested, they're not going to have access to services again. So we see that all the time with people that don't go, that don't want to start methadone or don't want to start buprenorphine, because they know that once they start, they're going to be most likely going to be arrested at some point in their journey, and they don't want to go through the withdrawal and then not be given that when they're incarcerated. And then there's also just archaic prescribing regulations around most of these medicines, and it makes it really difficult for people to have access. So from the individual and community level, people who use drugs tend to have a higher prevalence of other health and mental health issues, higher prevalence of trauma, poor social support, higher levels of previous incarceration, higher levels of homelessness or precarious housing. So we have to also remember there are tons of housing restrictions for folks, right? There are some states that if you've overdosed in your own house, your own apartment, you can be evicted. So there's like endless, again, like just endless barriers. And then for a lot of people, they have poor relationships with the healthcare system. And then when we look at it from an institutional level and a structural, framework, we can understand the inequities here. So majority of people who use drugs are white. I mean, the numbers are similar, but go higher on the white scale. But African-American and Latino people who use drugs are 5 times more likely to be diagnosed with AIDS. People who use drugs face stigma throughout their life in society, institutions, focus on criminalization over treatment, prevention and care, and then overdose is on the rise. So these are just some of the harms related to people who use drugs. And then here's some social determinants of health, right? So social determinants of health are social, economic, and political circumstances that influence individual and community health status. And so kind of looking at it from a structural, again, community, interpersonal, and individual levels. I was also going to just say, like, even with I'm going to speed past stigma because we don't have a lot of time, but, just think about like treatment services are just labyrinths, like just everything here, trying to get services really for anything is an absolute labyrinth. Okay, I'm going to go past language to, all right, so the data about harm reduction, there really is just incredible volumes of concrete data that say about harm reduction, reducing morbidity and mortality. We know that syringe exchanges have shown mean annual decreases in HIV seroprevalence. We also know that the use of methadone maintenance really is strongly related to decreased mortality. If you even look at buprenorphine as a protective factor, buprenorphine decreases overdose risk rate by 50%, also decreases hepatitis C risk by 50%. We tend to not talk about hepatitis C, and hepatitis C is doing the same trajectory as overdose is right now. Also to just kind of look at the most recent addition in the harm reduction continuum, which would be overdose prevention facilities. They're all over the country. Thousands and thousands of people use them, and there has been 0 deaths, right? So we got to think of we have to be a little bit creative. People always talk about like overdose prevention sites. It's like the Hail Mary. It should be the fucking floor. Safe supply is what we need to be going for. That's just my personal opinion, right? But we need to have these places where people can be safe, but also we have a poison drug supply at the moment. Okay, so syringe services have decades of evidence to support their benefits, ranging from HIV, HCV, and soft tissue infections, and supporting the most marginalized folks. So the greatest thing about harm reduction, or one of the greatest things, is that it's really needs-based and there's a low threshold. And really for most people, it's their entry point into healthcare and other treatment services. So I talk about this a lot. I used to be embedded in a methadone clinic. For some people, methadone clinics don't work. it's restrictive, and for a lot of people, it's an incredible resource, right? And I loved it because we got to see people every single day and got to see behavior changes, got to see different things. You got to see if someone had a wound that maybe was an abscess and maybe getting worse or whatever it was, but suddenly like we had eyes on people every single day. And so when you kind of look at methadone clinics, or at least my view of methadone clinics, is they're health centers. They're much, much more than someone going and getting their prescription and leaving. They're someone that goes and gets their prescription and has a conversation, has a cup of coffee, has all these other kind of ancillary wraparound health services. So we know that no barrier naloxone access works, right? We really are supposed to be putting naloxone directly into the hands of people who use drugs, not kind of sheriff's departments, not other places like that, right? We're supposed to be giving it right into the community. Okay. So stimulants and harm reduction are an interesting group because our harm reduction playbook, for the most part, has been built around opioids. And so many of the behaviors, sorry, I was looking at my eye, many of the behaviors associated with people under the influence of like crack cocaine or methamphetamine, including like rapid speech, maybe highly sexualized behavior, agitation, jitteriness, skin picking, that really amplifies a lot of the stigma associated with them. And so those behaviors tend to make them visible targets of further judgment and scorn. And harm reduction providers have really noticed the challenge of creating integrated and accepting spaces for people who specifically use stimulants. So harm reduction for stimulant use overlaps with harm reduction for other classes of drugs, but it's also really distinct in several ways. And so, you know, when we're thinking of like, this is even a problem that I think about a lot, like we're talking about safe injection sites, and we're not talking about safe smoking sites, and we're not talking about places for people that use other substances. So even within the harm reduction community, even within our own community, we are still marginalizing and pushing people aside with certain substances. You know, there's really specific things that we can do to be really inclusive of people that use substances, stimulants. You know, they might need more space to be able to walk around and burn more energy off. And so those are kind of the things, right? And we don't even I think about how we don't do trainings on overamping as opposed to overdose. Like there's so many things that we do to kind of, even within drug use, fracture and kind of push people further and further. So stimulants and harm reduction are kind of a uniquely stigmatized and marginalized population. And there's really just a lot of limited research around stimulant use. Okay. So some of the impacts of prohibitionist drug policy on health have been that the stigma associated with the criminalization, incarceration, mental illness, race, and class reduce the opportunities for tailored medical and social services. They have led to worsening social determinant of health-related outcomes. It's contributed to a moralistic instead of a science-based understanding of drug use and substance use disorder. And then, you know, things like we've discussed, syringes are possession of syringes are criminalized, incarceration and people accessing that, et cetera. Okay. So get into the structural violence. So structural violence, so discrimination and structural violence. So participants' fear of utilizing healthcare services stems from being treated differently, from being shunned, from being labeled with assumptions being made about them that are going to result in poor quality services. So the fear of using healthcare services is often realized when the person comes face to face with the healthcare services. Limitations to health information is a source of structural violence, right? So when folks have to rely on informal education and informal education networks because they can't access it from the source. And then forced choice of structural violence, right? So when we look at drug courts, that is structural violence. Choice has the connotation of possibility and a range of alternative. When you only give somebody like one or two things, that's not choice. Or a forced choice by saying you do this or you're incarcerated is not choice. So if you create a system where people who use drugs can't be honest about their using drugs to medical professionals, or you deny them care, you're actually creating a system in which you are killing people who use drugs. Medical, it's really important that we remember that medical conditions occur because of and outside of drug use. People have other things outside of their drug use. And so this gets a little bit murky because, well, I'm going to bring that up another point. No, I'm going to say it now. Okay, so the medical model is physician-centered. So physicians, so you all are, most of you all are going to be prescribing treatment plans based upon the information in which you are the credentialed expert. So the medical model relies on the physician as the locus of control in the delivery of care. And the harm reduction model relies on the actions and the decisions of the person accessing services as the locus of control. It's user-centered. So this is where it starts to get a little bit tricky, because if you're having a credentialed expert as the locus of control, but harm reduction is saying that the participant, the expert, is the expert in their own life, is the locus of control. This is where it gets a little bit uncomfortable. So the provider really kind of has to understand that they're going to have to be given away some of their power, or the idea or the perception of power, right? And so this is something I think that everybody I always want to encourage people to think about, is that how does harm reduction fit within the medical model? How does it not fit within the medical model? Because if you are the credentialed expert in your field, or this is how we have set up, medicine in this country, and then harm reduction is saying kind of the antithesis, how does that work? How are we going to balance the two? Sorry, jumping between two. Okay, so some of the harms within medicine. So people who use drugs have historically been treated pretty badly in medical homes, which has led to avoidable illness and death. So some of the harms within medicine are the ingrained bias, judgment, stigma, and discrimination that some providers carry, underdeveloped infrastructure, the racial stratification of health insurance, who in this country has access to medical care, MAT access for folks, for our Black, Indigenous, and people of color population, chronic pain patients, it's a huge one. Right, and we even understand how Black communities and brown communities tend to not be believed when it comes to pain. Mandated reporting. So again, I said this earlier, so medicine becomes an extension of this, the police surveillance state. Pejorative language that's used, so things like frequent flyer or drug-seeking behavior. When people are refused syringes at a pharmacy, refusal to prescribe or have a discretion around PrEP. This is one I see all the time. Shaming and bullying in phlebotomy. A doctor's decision to not use lidocaine before an incision and drainage on someone who injects drugs. Intentionally being rough with swabs. Diagnostic overshadowing. The idea that the drug use is the only thing that possibly brought that person in, right? Not understanding that there's something else going on, that we're just solely focused on the drug use. So ignoring what that patient might have brought to the clinic instead of focusing solely on their drug use. Drug testing without consent, so the lead to DCFS involvement. There was a big case in New York recently where there was a study that supposedly a hospital in New York was doing, now I can't think of the word, random, oh my God, sorry guys, it's been a long day. We're supposedly doing random drug testing, but then when they actually went through the data, of course they were not. They were doing drug testing on Black and brown folks. And so we see this consistently with drug testing within hospitals. And then strict appointment scheduling and high barrier is a huge harm within medicine. So some of the harms within the medical field include racism, transphobia, stigma, economic instability, lack of care access, criminal justice involvement, and houselessness. Those things are what make substance use much more dangerous. You know, we even look at like the rise in congenital syphilis amongst people who use drugs. We can see the harm within that and why are folks not having access to care in that capacity. For those that have serious bacterial infections, so those with injection drug use related serious bacterial infection, they're 50 times more likely to die of an overdose than those without. And then just the understanding that our medical system is binary and constantly putting people in buckets. We're not understanding people as complex and human beings. So not to blame you all, but to look at the system here, right? To understand kind of our culture and care. So we have personal and professional exposure and beliefs. We also have like, you know, moral injury. So understanding what you want to do and not being, or understanding, doing what you think you need to do and not being able to do it, having your peer influence, and then you're also your personal and professional beliefs, which then all kind of filter down into thoughts, stigma, and discrimination, feelings, lack of empathy, compassion fatigue. There's, I mean, serious burnout, right, within the medical field. Actions, and then that leads to actions, which are the language and the behavior, which then is usually sometimes judgment, bias, stigma, and discrimination, and all of those eventually leading to barriers to care for folks. So how to convey a harm reduction mindset in medicine? It's how we speak, it's how we listen, and it's how we approach. So really it's about being transparent as your role as a provider, co-learning about related risks and behaviors, and deferral to patient decision-making. So I think one-to-one harm reduction really begins with honoring the patient. So we can start by saying, I'm really glad to see you today. Questions away from their drug use. How was it getting here for you, right? Looking to ways that that clinic or the hospital or wherever you're embedded in can support them in the future. Addressing the acute need, inviting a conversation about substance use, asking permission if you need to speak about it. Tell me a bit about how you're doing or what you're using. Do you have any questions about your use today? But really, ultimately, what would you like to see happen for you today? What's your priority? Oh, okay. And then that's about the syringe exchange. This is just a little basic harm reduction for substances, but I'm gonna go through that. This is some indigenous harm reduction, which is the 4-pillar model, which is pretty familiar. It's very similar to the kind of the harm reduction that you'll see within academic research, but it's community well-being. And so again, this is kind of things that have just been around for ages, and we've kind of like co-opted, and we've really forgotten that there's been harm reduction in communities from a very, very long time. And then this is what I end on because I love this woman more than anything. This is Heather Edney. Heather Edney worked at the Santa Cruz Needle Exchange. She is now a director at Homeless Healthcare. And many, many years ago, she started a zine for those that were injecting drugs. Heather's very open about her drug use, her past drug use. And she created zines about overdosing, about wound care, about absolutely anything that you could possibly think of related to substance use. And I really love all of these things because, again, these ideas that people that use drugs don't care about themselves, they don't care about their community, all these like narratives that we have constructed to be okay with the continued marginalization of people that use drugs. And these things really fucking push back on it. Like, these are communities that have done incredible creative things to keep themselves safe. So starting with Heather's zines, she's also featured in a book called The Politics of Naloxone. And there's a really incredible stories about her. They're gonna be doing a lot more work. But also these are some really just great resources for harm reduction and the understanding of people taking care of themselves. So Never Use Alone is, I think, my favorite resource. It's a 24-hour phone number staffed. A lot of times by people who use drugs, but a lot of kind of general community members have gotten a lot involved. What you do is you call, you don't need to give any identifying information, just your location. They then tell you to start using your substance once you've been connected to an operator. They ask you prompt questions every 30 to 45 seconds, and they keep you on the phone for about 15 to 20 minutes. So it's like a virtual spotter system for people that are using drugs. They have 100% success rate. So they have kept a lot of people alive. So again, pushing back on this narrative of people don't care, don't want to, you know, they're engaged in risky behavior. Bluelight.org is a really great website. It's a forum. It's mostly used by active drug users, and they really just discuss bad batches, their experiences, dosing. I mean, absolutely anything you can think of. I would really encourage, whether you use drugs or not, to go on Blue Light. An incredible wealth of knowledge. Arrowhead is has staff on it. It's a more an academic focus. However, there's still a lot of resources, especially on like dosing practices. Psychonaut is really a great place for people that use psychedelics and novel psychedelics. And then tripsit.me is incredible. So they will show you like the chemicals, and you can put in basically all the different substances you want to use or might use. And it kind of like does a risk calculation for you. And then syringe exchanges as information exchange. Okay, I think I did it at the 50-minute mark.
Thank you so much. Amanda, that was incredible.
I know I have like another 20 pages of notes, but I'm gonna shut up. Okay.
No, I'm really impressed that it's 7:50.
Thanks. I feel like I missed a lot, but oh, this is one point I forgot, Tucker. This is very important. When we talk about non-compliance, I think we need to really start understanding what or start evaluating what non-compliance means for us when we talk about people that are using drugs or people, you know, whatever the behavior is. Really thinking about, is non-compliance about us, or is it about that they're maybe the authority within their own world, and that system that we have created, or whatever the treatment plan we've created for them, just doesn't actually work. And then, yeah, the last thing, I didn't put this on here. I told you, you thought I was done. I'm not done. Is the reason why I love harm reduction, or one of the reasons. So when I used to work in a needle exchange, it's hard. It's, you know, there's constant kind of things that are happening, and a lot of times you can start to take on behaviors personally, and you can kind of see people passing away or things happening as like a personal failure, like you didn't do enough or you didn't do whatever. And I really think with harm reduction, it's really incredible because the onus is actually taken off the provider. And it, you know, you don't have to do constant like tick boxes and constant kind of like treatment planning and all these different things. You don't have to hit all of these like grant funding requirements, blah, blah, blah. You get to really celebrate small wins, and you get to celebrate things all the time for things that people might not recognize or might not celebrate kind of in external or outside of that, right? So like when you can move somebody from injecting to smoking, that's a huge celebration. There's a lot of protective factors. There's a lot of things that happen. So just to say that harm reduction is really great because you get to celebrate wins all the time. Anyway, yada, yada, yada. Okay, now I really am done.
That was so incredible. Thank you so much for taking the time. Seriously, it was really incredible. I really appreciate you taking the time tonight, 8 o'clock on a Monday night, to come and talk to all of us. Do you have time, Amanda, for some questions?
Yeah, of course. Oh, whoops, sorry. I just saw. Did I want to talk about language?
Oh, no, that's okay. That's okay.
Sorry. I can, but I'm going to send these to you. So
yeah, we'll send the slides out. I mean, I'll send them, and then we'll send the slides out to everyone. There's some good, I had just like messaged her. There's some really good slides on language that I think are really good for all of us to see. I know we didn't have time tonight.
Yeah. But as you can tell, I'm happy to talk forever. So if anybody, please do actually, but I should have discussed the language. Please do look over the language because it really is important. People hear what we say, they internalize it. Andrew, look at me. When you're having a bad day, I'm just gonna come back to this chat. Does anybody have any questions or anything that they need for clarification?
Yeah, I had a question.
Yeah.
I was wondering if you could describe some of the obstacles to methadone treatment.
Oh,
I heard it's one of the most like overly regulated prescription drugs.
the most archaic fucking laws. So do you want me to talk through, like, you mean, like, what are some of the specifics that you're curious about?
So I know that it's like regulated at the first level by like the FDA and the HHS, and then since it's a narcotic drug by the DEA, but there's a third level of regulation that I don't understand very well that sets it apart, I guess.
So no, the regulatory bodies are what you mentioned. But then even within the county, are you talking about, so then there's then even local rules within the county, which make it really difficult. So you can only have, so there's zoning, and you can only have a certain amount of methadone clinics within a certain amount of miles. So again, when we're talking about marginalized populations and access, we are becoming incredibly restrictive. And so when you look at the population of who tends to use methadone, or who tends to kind of be steered towards methadone versus who tends to have access to buprenorphine, there are vast differences, right? We don't have prescribing limits on how many doctors in a certain square mile can prescribe buprenorphine. Tends to be more white, cash paying folks that can access that. Interestingly enough, there was I was actually and then the lowest overdose rates were Malibu, where it was the highest buprenorphine prescribing. But does that answer your question in terms of methadone with the regulations for LA?
It does very well, thank you.
Okay, great.